Well, good morning, everybody. Thanks for getting up so early to join us today. Hopefully, we can give you some friendly tips and ways to think about advanced therapies and give you an update on the new AUA guidelines for overactive bladder. I would like to introduce my esteemed panel here, faculty who has been very engaged in putting this course together for the last several years. Let me introduce Dr. Sandy Vasavada, who is at the Cleveland Clinic. Dr. Ann Cameron, who's joining us this year as she was the head of the update of the AUA guidelines for overactive bladder, which we'll share with you hot off the press, and she's at the University of Michigan, and Dr. David Ginsburg, who's at USC. So we're going to open with some pre-questions to get you thinking about things, and then we're going to have a pretty much an open discussion about things based on a case-based discussion. So we want to make this very informal because there are so few of us. If you have any questions, please feel free to just chime in, and we'll make this more of a conversation than us presenting to you. So I'm going to go ahead and start with this quiz. Not really a quiz, a pre-test, just to help us think. And there's actually a QR code. Let me see. Let me put this up here for a second so you can scan that, and then you can do live streaming. Oh, by the way, there is live streaming going on here too. So just a reminder to the faculty as well, everything that we're talking about is being heard live out there in Cyberland. Okay, with that, let's start with the first question. Despite 6 weeks of mirabegron, a 69-year-old woman with recurrent urinary tract infections has urgency incontinence. She has early dementia and a cardiac pacemaker for bradycardia. Her exam is unremarkable. PVR is 125, and her urinalysis is negative. The next step is, please go ahead and enter your answers. Somebody on the faculty should answer also. So they said. Oh, am I supposed to go to I'm supposed to go to the next one, I think. Okay, that makes it the poll, right? Okay. We don't see the results on this one. Okay. Not till the end. All right. Question number 2, which of the following might be considered the most effective method of counseling for third-line therapies? So the first one is sacral neuromodulation involves putting a small computer in your back in a sterile operating room. Onabotulinum toxin A injection includes 10 to 20 needle sticks in your bladder, but you do get local anesthesia. PTNS requires a needle in your ankle every week for 12 weeks. Sacral neuromodulation involves placing an Oreo cookie-sized battery under your skin under colonoscopy-like sedation. Onabotulinum toxin A is a life-threatening toxin that has been used for many things like migraines and wrinkles, but it's safe. The whole point of this question is really language and how you present things to your patients. That's too far away, and this is too much to the side. I don't know how. I don't know the best way to do it. Thanks. Okay. Oh, I did that prematurely. A patient undergoing placement of a lead for sacral neuromodulation elicits bellows only. The next step is it working? Okay. Despite timed voiding and caffeine reduction, a 45-year-old woman has urinary urgency and frequency 10 to 15 times a day. Her exam is unremarkable, PVR is 15 cc's, and her urinalysis is negative. She is not interested in long-term pharmacologic therapy and is unable to do physical therapy due to scheduling issues. She would like to proceed directly to sacral neuromodulation. The next step is All right, and the last pre-test, pre-quiz, is a 53-year-old woman's OAB symptoms are not improved 2 weeks after injection of 100 units of monobotulinum toxin A. The next step is. Okay. All right, I think we need to go to the next slide deck there, Jake. Oh, I guess I do that. Okay, so hopefully again we'll be able to give you some practical tips. This is the QR code for the audience polling one more time. And then again, our esteemed faculty, which I'm very pleased to be up here with. Dr. Cameron, Dr. Ginsberg, Dr. Vasavada, and myself from Houston. These are our disclosures. Okay, so now the format of this is going to be very informal. We want it to be case-based to make it practical. So we're going to pause a little bit and have a little discussion, but have you be actively thinking about what you would do rather than us just presenting, a course to you. We encourage a very interactive format, as I mentioned before. We'll talk a little bit about sort of what's on the horizon and what the new stuff is. Again, we're going to use audience response and have a really open discussion. So, the OAB guidelines used to be, up until hot off the press, it used to be divided into first, second, and third line therapies. As you know, that's changed a little bit. And again, we have the privilege of having Dr. Cameron with us here today, who just headed the guidelines panel. So I'm going to pass the baton and ask Ann to come up here and give us an update on what the newest and latest is. Oh, you can use this instead of the mouse. I didn't realize.
Oh, yeah, that works great.
That's better.
Yeah, thanks. All right, so there were some significant changes made to the new OAB guideline because this wasn't an update to the current guideline. This was actually a brand new guideline with a new literature review. So unlike other guidelines where they just get updated periodically, this was a complete overhaul with a new literature review. And the diagnosis method for overactive bladder has really remained unchanged. You diagnose someone with history, you diagnose someone with physical exam, rule out other comorbid conditions, and use your clinical judgment to diagnose a patient. So that really hasn't changed much. But previous iterations of this guideline only focused on information in female gendered patients, and this guideline has included all genders. So our literature review included data on both people with prostates and people with uteruses, and we try to use gender inclusive language in the description of the guideline as well. We eliminated step therapy. So step 1, 2, and 3, tier 1, tier 2, 3, that language is gone because there is a lack of evidence that step therapy is actually necessary. There's no evidence that says you need to do oral therapy before what we used to call third line therapy. So we have implemented a shared decision-making model. And the shared decision-making model implies that you really discuss the risks and benefits with the patient and you factor in their preferences. And the reason for that is that overactive bladder is actually what we call a preference-centered condition. And a preference-centered condition is one where there's not really strong evidence that therapy A is better than therapy B. Drug A is better than drug B. There's actually no evidence to prove that, so why do we dictate what patients do when we have no proof that one is better than the other? So it's more important to factor in patient desire, patient needs, and their unique situation and provide them with information. So we have classified therapies by invasiveness, not implying that you have to go from least to most invasiveness, but just group them in those kind of categories. And again, shared decision making is now best practice. So the font's a little bit small, but we've grouped these therapies into things like incontinence management strategies. So we consider it appropriate to discuss ways to cope with incontinence. We know this doesn't treat incontinence, but things like diapering, excuse me, if someone had skin excoriation, suggesting barrier creams, behavioral therapy, is the next category. And these are things that patients can do on their own at home. They don't need help. Things like time voiding, urge suppression, avoiding bladder irritants. And then there is optimization of other medical comorbidities. So this is also a new aspect of this guideline, to consider other medical conditions that are known to affect overactive bladder. So someone who has significant constipation, addressing their constipation. Someone who is using a lot of diuretics, maybe addressing that with them and their cardiologist. Obesity, diabetes, genitourinary syndrome of menopause, we call vaginal atrophy, pelvic organ prolapse, and tobacco use are all comorbid conditions that, when treated, can improve overactive bladder. And again, this is all part of shared decision making. Behavioral interventions are things that basically should be offered to all patients. So this is just a list of those. And patients can offer non-invasive therapies to patients. And these non-invasive therapies, we consider those to be things where there is someone involved in the therapy, perhaps a therapist, perhaps a physician. But this is things like pelvic floor muscle training, which, we're talking about formal pelvic floor physical therapy, transcutaneous electrical stimulation, transvaginal electrical stimulation, but we're not saying that they're all equally effective, but they're all things that you can discuss with your patient, and you'll notice that there's a may offer. Whoops, sorry. And again, you can also combine therapy. So if you try one therapy with a patient, you can combine different layers of these therapies together depending on what your patient desires to do and what their wants and needs are. And again, if a patient is unwilling or unable to do these therapies, so if someone doesn't want to do pelvic floor physical therapy, they live too far away, someone can't do fluid restriction because they have needs for hydration that we can't control, like they have kidney stones, you can offer them more advanced therapies. There's no rule that someone has to do fluid restriction to be able to get, say, for example, botulinum toxin. So again, it's all part of shared decision making, and you and your patient decide. So again, non-invasive therapies are things that are provided by a healthcare professional involved. Some of it may be done at home, but things like PT, biofeedback, pharmacologic therapy, we're all familiar with the anticholinergics and beta-3 agonists. Again, minimally invasive therapy, we have combined that to include botulinum toxin, percutaneous tibial nerve stimulation, implantable tibial nerve stimulation is also included in there, as well as sacral neuromodulation. And then invasive therapies are things that we would consider to be pretty high risk. And those are not in the same level with the shared decision making. Things like an augmentation cystoplasty, that's not something that we would consider to be part of the shared decision making, because there is evidence that that is very high risk, as well as indwelling catheters. Again, those are considered more of a last resort, but they're discussed in the guideline. All right. Again, these are just the actual guideline statements themselves. And some common sense stuff. If you start someone on an oral agent and it doesn't work, you should probably stop that therapy. No kidding. You should measure post-void residual in someone that you suspect might have elevated residual, someone like a male patient or someone who has dysfunctional voiding, but you don't absolutely need to get a post-void residual. And we also address telemedicine in the guideline, because some patients can be addressed their concerns, and they can have a visit via telemedicine, knowing that you don't have a post-void residual or physical exam. But again, we offer some guidance on how to do that safely and effectively. So again, it's a menu. It's not a step anymore. All right.
All right, so thank you for that update, Dr. Cameron. That's great. We've got to think a little bit differently than we have in years past, now that we've gotten updated. So we're going to talk about some cases. Again, we're going to base our discussion here, very open sort of banter. Again, if you have any questions, please feel free to step up to the microphone. And forgive us for looking like we're on our phones. This is live streamed, so there's a lot of chat going on, and so we're trying to keep up with that, and whoever's not standing up here is trying to answer the chat, so please don't think that we're like texting our friends or anything while we're up here. So these are the cases that we're going to base our discussion on. They're very simple looking cases, but there's a lot of discussion to be had. So a female patient with refractory overactive bladder, a male patient with refractory overactive bladder, dual incontinence, which is both bladder and bowel incontinence, which we should all be asking about if we're going to be doing things like sacral neuromodulation or even percutaneous tibial nerve stimulation, and then neurogenic bladder. So we're going to use this to base our discussion and hopefully cover all of those advanced therapies and sort of thinking. Some of the take-homes we'd like you to be thinking about is, when do we introduce minimally invasive or even invasive therapies in our algorithm? It's not really an algorithm, but in our discussion, in our care of patients. Some counseling tips, some language to use so you don't scare your patients away with things that are really not that invasive. So we don't want to scare our patients away. It's how we present it. Is one minimally invasive therapy better than another? In some cases, the answer might be yes. Others, it's just very much a shared decision-making process. Optimizing how we do this in your clinic flow, right? Some things we do in the clinic, some things we do in the surgery center or outpatient OR. You know, how do we optimize that flow so the flow doesn't become a barrier to us offering these therapies for our patients? You know, engaging and empowering your staff, which is a tremendously valuable thing to do, because if your staff feels empowered, they get really excited about it because they're an important part of the care, and that makes your flow better just by virtue of the fact that everybody's engaged. Minimizing the hassle factor, optimizing lead placement. We'll talk a little bit about that and some troubleshooting, and so we've got a lot of things to cover, and we'll do it in a case-based way. So first one is that 54-year-old woman with refractory overactive bladder. She's failed conservative measures, not enthusiastic about medications. Okay, so we've all had those patients, right? Especially where I moved from in the Pacific Northwest, everybody wanted everything au natural, so no one wanted to have medications. Do you have to have medications, Dr. Vasavada? Do you have to try medications first, or can you jump right to whatever you want?
No, I don't know if you really have to try medications, and I think what Dr. Cameron showed you with kind of the new update to the guidelines, or the new guideline rather, is you can use shared decision-making with your patients and really have an active discussion on how they'd like to proceed. So, you know, I think the step therapy mindset in me, and this is having helped author the first 3 versions of the guidelines, so it's rather difficult to sort of deprogram yourself to thinking step therapy. But that said, you know, the previous guidelines, I think, would have strongly suggested one way or the other to do a medication so that you could proceed on to advanced or third-line therapies. So I guess I'd love to pass it back to my colleagues. How do you kind of change your mindset now in 2024 and beyond in that same context?
Well, even in the patient who says, I don't want to take any medication, I still discuss them with them, because many patients, you know, they tried an oxybutynin tablet 10 years ago and it was awful, you know, a 5 milligram immediate release, and it was awful, and they couldn't speak for half the day. And so they think all bladder medications are like that. So I think it at least, you know, merits, and again, the guideline says you should discuss oral agents with patients in this situation, and I think discussing them is warranted, but again, having an honest discussion with them about the medical therapy, because it's permanent medical therapy too.
Right.
It's not something you can take for 6 months and you're better.
Before I ask David what next question, how many of you are still using something like oxybutynin in your practice? A little bit? Okay.
Not because I want to.
Yeah.
Well, I think that's going to be our challenge, and it continues to be our challenge moving forward, is we want to provide a therapy that we think is effective, and there is a therapy that is effective, but sometimes the insurance carrier doesn't allow us to provide that therapy.
Have any of you had any trouble with the insurance telling you what to do? I mean, crazy, isn't it?
So you know, I've said this before, my mantra is that insurance providers at times will use our guidelines to deny care, but then sometimes ignore the guidelines when care should be provided.
That's true.
And just puts a lot of extra work on our staff and us to try to get things through when they're not being approved.
Do you think we're out of the era of trying, you know, it used to be you would try an anticholinergic, then you would try a beta-3, you'd do combination, all the stuff. We would stay on pharmacotherapy for a really long time before we moved to the next step. Are you all doing that these days, or y'all? Y'all doing that these days?
So you
In
never
Texas.
used to say y'all until you moved to Texas, KK. What's going on over there?
So,
mean-
yeah.
No, I mean, I think we've kind of learned there's not a reason to go to. I mean, I think the one that's the most frustrating are the providers that say you have to go through 3 medications. You have to do 2 anticholinergics and 1 beta-3, of which there is 0
Evidence.
anywhere in literature that says you have to do that to go to any more of an advanced therapy. When Mrs. Schwartz comes in and she has 0 response to what we think would be a good oral therapy, it's unlikely you're going to add it. She's going to be better with the other therapy.
Right.
Um,
Right. Yeah, so some of these things I want to think about, how we counsel and when you introduce minimally invasive therapy. I tend to introduce it when, if somebody comes to us at Houston Methodist and they've already been on medications, obviously you start talking about third line therapies. But even if somebody comes to us having not been exposed to pharmacotherapy, when I write their first prescription or give them their first bit of samples, I start telling them about minimally invasive therapy already, because we don't want them to go, we used to say, okay, here's a prescription. If it doesn't work, call me. Then they're not going to call you, right? If you say, okay, I'm going to see you in 4 weeks, 4 to 6 weeks. Actually, when do you guys follow up after you do pharmacotherapy?
If it's a medication that I know is going to be approved right off,
Yeah.
then I'm more in the 4 to 6 week range. If it's a medication that I see, it might be a beta-3, I'm looking on my computer and I can see it's, on my medical record, green is going to be cheaper, red's going to be bad, and yellow is going to be maybe. So if it's maybe yellow and I know I'm going to have to do a pre-auth or something like that, I may say 6 to 8 weeks. I know they're not going to get the medication immediately, so I have 2 weeks to work on the PA, and then they come in and they get the medication. So they just have 4 to 6 weeks.
Okay. Well, I mean, we do make a follow-up, and I introduce the concept
When you
of...
say introduce, do you give handouts? Do you just
I do.
tell them?
I do. I tell them about it, and I say, if this doesn't work, I say to them, we'll talk about scripting, actually. The next question is scripting, but, I will tell them, I don't want you to get discouraged. It's not that I'm not optimistic that the medications might work, but just in case, I want you to know there's a reason to come back to us because we've got other things. How do you talk to them about it, Sam?
Yeah, I think same way. Try to introduce it early, giving them as many of the options up front as possible, knowing that they know somewhat of the journey. Because as David mentioned, sometimes it's a prior authorization, sometimes it's, they can't get the medication, they don't tolerate it, and if they just call into the office, perhaps your nurse or a healthcare provider will say, oh, we'll try in a different one, oh, let's just use this one, it's cheaper. And the problem ends up being is that they start to spin on these medications, and as we've already alluded to, I think the success rate with trying a second, a third medication is quite low. So at least giving them an option to say, hey, there's other options that we can do to help and follow those patients out with a little bit of time. And then I think, having somewhat of a formal follow-up. We've been doing other virtual visit follow-ups because these are really ideal. You've seen them once in the office and then a virtual visit for a follow-up for that. Or if you have an APP that you work with, to have them follow up with them too.
So I think it's key to keep the patients engaged, right, and coming back. So I think that if they have a reason to come back, that's important. And we didn't used to be that good about doing that.
Yeah, KK, one of my partners created a shared decision-making model for the minimally invasive therapy. So I actually give that to every patient who shows up because I find some of them are pretty hopeless. They're like, oh, I'm just getting a medication. And, they're wearing 4 diapers. And, it's not like I'm like really enthusiastic about this oral agent for someone with severe symptoms. So I tend to give them, we're not doing this now, but this is some food for thought for our next meeting where, if this doesn't work, this is what we'll be talking about next.
Yeah.
So I find that it gives people a lot of hope because there's like, oh, there is something that you can do for me.
That's right. I think that's important. Anything else to add, David? I think I was putting this in here as far as the data out there that supports medications, but...
No, I mean, I think data is certainly important. It's important. It may be more important in terms of side effects, right?
Yeah.
And maybe avoiding certain medications in certain patients. We'll allude to some of that later on in terms of certain patients you may want to give advanced therapies to versus certain patients you may want to avoid using certain advanced therapies based on the data.
Right.
So absolutely.
So again, some of the take-homes just from this little discussion, and we're only going to get into the meat of it with the next few cases, but, get to minimally invasive therapies a little sooner. If the meds don't work in a month, they're not going to work really. I mean, so do you want to do combo therapy and all of that? It sort of depends on the sort of hassle factor. Introduce all these options early so the patients start digesting all the options that may be coming their way. It's all in the presentation, right? You can get your patient to, choose something that you kind of coax them to. So you want to make sure that you present things, balanced and in friendly language, which we'll share with you, that doesn't intimidate them. So we'll kind of share with you our little scripting things. Goal setting and establishing expectations for the patients is great right from the very beginning. My apologies. I did not read this, the statements that I was supposed to read at the beginning of the course. I'm not going to go through the whole thing because you're all signed on already, but I will say, for every course evaluation that you complete, your name will be entered into a drawing for a complimentary registration to the next year's AUA. So that I think is important for you to know. That can, save some dollars and cents. And you can evaluate this session. Well, there will be through the mobile app and through that QR code, I believe. So I'm going to go ahead and go on with the other things. Thanks. Okay, case number 2 is a 62-year-old male with overactive bladder symptoms. He's got urgency with occasional close calls to urgency incontinence. He's got frequency every hour and a half and nocturia times 3 at age 62. Mild obstructive voiding symptoms. PVR is only 20. And he's failed mirabegron and declines an antimuscarinic. Okay, so kind of in that refractory category, he's tried what we used to call first and second line therapies, but conservative measures. So are there caveats for males? Does anybody think differently about a male than females? Dr. Cameron?
Yeah, I mean, there's always a heightened possibility that he does have some bladder outflow obstruction. So that is not a rare thing in this population. He also has some symptoms of it. His PVR is not elevated, but it takes a lot of obstruction for someone to have their PVR elevated. So in someone who presents like this, I think that the mirabegron trial was a great idea. Low likelihood of putting them into retention, and there's some, there's good evidence that men who even have a little bit of obstruction tend to do very well on the beta-3 agonists. But you still have to keep the possibility of obstruction in your mind. So in this guy, I would probably aim towards the alpha blockers, combining alpha blockers with the beta-3 agonist before moving on to anything else. And me moving on to anything else would probably, other than tibial nerve stimulation, which I think is lower risk than the urodynamic study that I'm going to do, if he was trying to avoid anything more invasive. But I would do urodynamics before moving on to
so that
botulinum toxin, sacral neuromodulation.
Yeah, what is the minimal workup for men, David? What would you do?
I think the minimal workup in any OAB patient is history, physical exam, and urinalysis, and that's always the case. Yeah. But that being the case, we're urologists, we have all of ultrasound scanners in our office, and we're all going to do an ultrasound to look at the PVR, right? And you can even do a Euroflow if you're concerned, but when the guy that comes in with zero obstructive voiding symptoms and no PVR and terrible OAB symptoms is very different and often rare than the guy that comes in with, my flow is not as good as it used to be because it just happens with age with us men, and PVR is maybe not 0, and then you're like, okay, I've given you an alpha blocker and some oral medication, and I'm at that crossroads of, am I going down a prostate pathway, am I going down an OAB pathway, and depending upon the patient, I mean, I don't. It doesn't take a lot for me to do a urodynamics on those patients. Yeah. Sometimes, my fellows always tease me because I always say, well, it's a treatment and a test, because I may go and try, depending upon the outcome, I may try a botulinum toxin injection, and if they do great, fantastic, and if I put them into retention with botulinum toxin, I'm like, okay, well, I guess I should have done something for the prostate, and that's my next step. Not necessarily retention, but just an elevated PVR.
But if I could add one thing, and you had it on the last slide about what about PTNS, and I think those are great discussion points, because to just say, okay, let's do PTNS, the standard is typically once a week for 12 weeks and once a month thereafter. So, if we're going all the distance of 12 weeks, now you've committed potentially an obstructed male patient to coming into your office. If you come into any of our facilities, you're probably paying $10, $15 to park every week. and then doing the hassle and the effort of doing all that. So
Right.
I'm not minimizing the insult of urodynamics, but I do wonder that is it better to just go ahead and study a patient like that?
I would also like to add, and
That's
I've
fair.
heard this every year, that I'm still surprised how remarkably expensive it is to park at the Cleveland Clinic.
Yeah, I was just going to say $15. Are you serious? So, how do you choose? I mean, I do. I'm of the thinking that we should confirm before we do something invasive to a patient. I want to confirm that I'm concentrating and focusing on the right thing. So I would tend to study to confirm that they don't have enough outlet obstruction. That shouldn't be the first thing we take care of, right? So, how do you choose? I'm going to pass the baton on to Sandip and ask him to talk a little bit about PTNS and we'll also talk about some of the things that are right on the horizon as far as PTNS toward the end of this course. But let me pass this on. Thanks.
Great, so most of you know this. PTNS is typically this peripheral neuromodulation technique. It's been out for years in the United States. It's been out for years, even prior to that, ex-US. Most of us have kind of used this analogous to an acupuncture-like technique. Marshall Stoller and the afferent nerve stimulation SANS device was really the origination of it here in the US. Again, prior to that, iterations from Far East that have, I think, really borne out. It's interesting, I talked to a friend of mine who was a pain therapist, now has moved a little bit more into the acupuncture realm as part of what he does. And I said, if I sent you a patient and I said her problem is overactive bladder, she said, do something for me. Where would you put your needles? And he showed me exactly where we would put a PTNS needle. So there is a lot more truth to what you think on that. When you look at tibial nerve, typically the default standard has been once a week for 12 weeks, and then once a month thereafter to maintain the stimulation. Remember, this relies on carryover. So carryover means today is Friday, but I want my bladder behaving on Monday when I'm watching the game or something. So to the effect that it's still working, it probably increases with the stimulation and then decreases over time. Then you hit it again a week later. And then when you continually do that, especially in the peripheral nervous system, this carryover phenomenon does tend to reside well, and then these patients continue to maintain benefit when you even do it less and less often with time. But it probably still does require some level of maintenance therapy, and we'll even talk about how that relates with the implantable tibial nerve stimulation. The big challenge is it does require travel. You may not have to pay $15 to park, but somehow or another you're paying gas money, you're doing something to make the effort to go into your office setting, having that 30-minute treatment, going home, and that can be disruptive for a lot of people. The technique is literally as follows, so really just a few finger breaths above the medial malleolus and about one finger breath back, placing the needle at that level, and then getting a sensation at the sole of the foot that's a kind of a numbness, paresthesia sensation that they typically know that they're in the right spot. And then getting that once a week for 12 weeks. And so, as we'll talk about with the implantable devices, what's different with this percutaneous technique is it's somewhat inexact, right? I mean, you're relying on someone's ability to place the needle, get the right stimulation each time, as opposed to when you do an implantable technique. Once you implant them, it's right close to the nerve, and you can get probably a more effective and reproducible stimulation each time. When we look at that, it's pretty simple, small, 34 gauge needle. So when we originally learned it, the reps actually showed it on themselves because that area is relatively insensate. It's not the more sensitive parts of our body. The needle should be near, but not necessarily on the nerve. And then the grounding electrode is on the medial portion of the calcaneus. And then this is the stimulation settings, usually with a fixed frequency of about 20 hertz. Contraindications. So it is technically contraindicated in patients with cardiac pacemakers and defibrillators, those who are pregnant, technically those who are seeking pregnancy, and relative contraindications, obviously those who've had some level of neuropathy or nerve damage on that side. So then the question still comes up, do patients tolerate it well? Yes, they tolerate it exceedingly well. We did a study several years ago. No complications, patients did well, pain scores like minimal, if any. So I think, when you talk about all the other options that we do mention, from a safety and a tolerability standpoint, this is about as close to a win as you're ever going to get. The overall success rates, I'd quote them a little bit higher than medication, but I don't feel like it's in my most robust of refractory overactive bladder type therapies. And so I suspect, like Ann mentioned, with a patient who's wearing 4 pads a day, heavy pads, soaked, I mean, is she going to be, and she responded none at all or minimally to an overactive bladder medication, and she's like, I just got to get therapy. And I'm not so sure that this is my patient who's going to be, singing my praises because we brought her through the PTNS
Yeah, and
treatments.
there's no, again, with the literature review, there's no direct comparator studies, there's no randomized head-to-head comparison like there is for botulinum toxin and sacral neuromodulation. The
Right.
best there was a prospective, non-randomized patient choice PTNS versus botulinum toxin, and this did not do as well as the botulinum toxin, and everyone's shocked. No.
Right.
There was a question in the chat.
Yeah, please.
Regarding home kits for
Yeah.
PTNS.
Yeah, I think that's a great question because that comes up. So home kits for PTNS, I'm not aware of any home kits themselves, but what we've all done is use some form of transcutaneous electrical nerve stimulation. I remember a few AUAs ago, I was sitting on the podium with Lynn Stothers, and for those of you who know Lynn used to practice up in Canada before she moved to California. But someone presented an abstract on PTNS, and she kind of looks over at me like, why do you guys keep bringing them back? Why don't you just try the home kit after that and use the transcutaneous? And so as we talked about it more, like that's what they were doing in Canada, and many of you, if you're outside of the US, probably do that as well. So then it's just placing a transcutaneous patch, so either a TENS unit itself, which you can buy on Amazon or a lot of medical supply stores easily, and then putting that in that same distribution, trying to ask them to where they're going to feel it. Again, it's kind of the paresthesia feeling on the sole of the foot, maybe even a little bit of ipsilateral toe flexion to know that you're on the right spot, and then give them the opportunity to do this maybe more than once a week. In fact, we'd usually recommend it 2 to 3 times a week, if not more, at the beginning. Anyone else have experience with that?
And I thought it was a little bit hocus pocusy, but there was a very well done systematic review
Yes.
included in the new guideline that showed that it worked as well as the percutaneous. We have a question from the audience. If you want to come to the microphone,
Yeah,
so
I think that way the
audience can hear
people,
you,
the
but you're
virtual
welcome
audience
to
can
come on
hear.
up.
One of the biggest impediments that I saw was that in my patients with Medicare Advantage plans, the copays were just unbearable with PTNS.
Yeah, so for those of you online, the question was about the Medicare Advantage plans and then the copays with PTNS. I think there's some truth to that. Again, not to belittle my $15 a month, a week payment of parking, but you add that, you have the copay times 12 sessions. I mean, it can in certain situations get very, very expensive. So hopefully your office manager, someone's able to give some level of upfront transparency, because we think of it such a quick, easy, minimally invasive as it is, but the cost element could be a real factor.
Great. Did you have a comment, David?
Nope.
Okay.
All right. And then, just overall, again, we'll talk more as we go over contextually with the other implantables and others. But as Ann mentioned, the outcomes are actually pretty good when you look at that. We do emphasize that the patient should complete the whole 12 weeks of treatment. And then, again, they need to understand that they're going to need some form of maintenance. And then, as we'll talk about with implantables, there's been some predicate by at least a couple of the insurance companies that someone should try and succeed with percutaneous tibial nerve stimulation before they're eligible to go on to implantable tibial nerve stimulation. So you're taking a success patient.
So, Santa, what do you do? What is your strategy for patients during their initial 12 weeks? Do you see them at all during that time to give them a pep talk? Is it just your PA, whomever is doing that? Any strategies to pass on?
Yeah, great question. I think the reality is you do have to follow them up. You can't just be, okay, I'm going to see you now and then see me back in 3 months. So to the end, we have our nurses doing it, and when they're doing it typically at week 6, we have them re-administer a UDI-6, and so some form of an objective assessment, a subjective assessment rather, of how well they're doing. We don't go so far as to do diaries and things. Have you guys done anything differently for follow-ups on these?
No, but I will emphasize, is this on? I will emphasize that we do encourage people to get through the whole 12, which seems, I've had patients who weren't really thinking it was working too well at the 6-week mark who actually did well by 12 weeks. I feel sometimes like it sounds like you're trying to sell them something.
Yeah,
you know,
you feel like a
you have
cheerleader.
to stay until the 12 weeks. But there's plenty of data out there that shows that the 12-week mark is an important landmark time. So if you can encourage them in spite of maybe not super encouraging results at the halfway mark, but we do touch base with them for that very reason, to encourage them. So I think that's an important piece of information.
And Sandy, I have some live chat
Yeah.
comments. Someone provided a comment that Elitone, Elitone, is a home kit.
Okay.
Someone commented, and someone asked, what about regular acupuncture? And they put in brackets, more expensive than parking, but any data?
Again, no one's really done any more hardcore data recently on acupuncture and its overall utility in this situation, especially with the kind of outcomes that we try to, pull in, obviously based on guidelines and other ways. But again, it subjectively is definitely encouraged. Can you get to your acupuncturist that often? I think that's the only, again, other question.
And the data in the systematic review that we did with the guideline, it was like pretty
Yeah.
come see, come saw. So it wasn't, it was
Makes
either,
sense.
the electrical stimulation, I think, was what was efficacious, either transcutaneously.
Transcutaneously.
Or percutaneously.
Right. And then, if you can do this more often, again, as it kind of takes the conversation into implantable tibial nerve stimulation, but, when you're doing it more often, there has been some PTNS data that shows it probably works a little bit better. As I said, just some practicalities limit that.
Yep. And so, yeah, in summary.
And so just lastly, just summary of this, some of the pros and cons. Pros, it's minimally, if any, invasiveness. Cons, hardly any. It's just the convenience or inconvenience coming back. We talked about some of the relative and firm contraindications. It is probably the most minimally invasive option that we have with no inherent side effects. And as I mentioned, practicality and the maintenance side is going to be an issue for many patients. Okay.
Thank you very much. Okay, so let's go on to the next case, which is a 48-year-old woman who's got dual incontinence, which means both bowel and bladder incontinence. By the way, this course will be available for those of you who are trying to record it. It's actually going to be available for you to review afterwards, so you don't have to be holding up your phone. So these patients have failed. Again, you can see these slides predated. This is literally hot off the press, the new guidelines. So failed conservative therapies, right? So behavioral therapies, avoidance of bladder irritants, avoidance of excess fluid intake volume, and then pharmacotherapy. But she has also fecal incontinence, or accidental bowel leakage, we call it nowadays, in spite of a high fiber diet and physical therapy. The best option, really hands down, is going to be some sort of neuromodulation. And, the percutaneous is not quite as successful as the more centrally located sacral neuromodulation, but I think this is the one time where you just go straight to saying, okay, sacral neuromodulation, because onabotulinum toxin A is not going to help with the bowel situation, right? So this is kind of an easy one when they've got both problems going on. So how many of you do PNEs? Okay, and how many of you do staged? And how many of you do both? Okay. And I think that there is, some of it is the practicality of the flow in your office. I mean, I used to not do any PNEs at all, and now I do PNEs. The ones that I do staged are patients who either can't tolerate it in the office or who have a pain component. Those patients I definitely do staged, or somebody who's failed a PNE, which I used to think, honestly, in true transparency, I used to think that was a little bit of a racket, because I'd say, yeah, so if I'm going to do a PNE and it doesn't work, I've got to do staged anyway. That's just an extra procedure, and I felt kind of like, not quite great about it. But the fact is, patients do really well with PNE. I must say I had to eat my words, and so I do a lot of PNEs now that I didn't used to do. How about you
But
guys?
also things change because the electrode for the PNE improved.
Yes,
So
that's
back
true.
in the day when you were saying that, it also made sense because the electrode wasn't as good, but we have the improved
Yeah.
electrode.
Thank you for defending my, no.
Very good decision making at the time.
Well, I didn't want to clog up my office. That was the other thing. PNE or PTNS, all those occupy a room, and it doesn't necessarily occupy staff to do, for a long time to do PTNS, for instance, but it does occupy your room, right? And so PNE occupies both. But once you use the landmarks that we're going to talk about here, you can really do it pretty quickly. I mean, it's a pretty quick procedure.
Do you use fluoro in your office?
I do.
Yeah.
Yeah. And that makes a big difference. You can get it in a lot quicker. But, this is also, again, an opportunity for staff engagement. They really feel empowered to be a part of the patient's, care and outcomes, and they've got some pride in the fact that they're really contributing a very important piece of this journey for the patient. So, and lean on the reps, because the reps are very helpful. They can come in and help reprogram and that sort of thing, and you can empower your staff to learn it, but really the reps from the companies can come in and help you with the programming and stuff, so you don't tie your staff up. All right. Are we doing our best? There are tricks to optimizing lead placement. All of us here were in the era of when we used to have to cut down. Have you all seen that, when we used to have to make an incision over the lower part of the back to get to the sacrum? That was kind of insanity, actually, when you think about how far we've come to now being able to do it accurately with with percutaneous placement. So the aims for the placement are to be able to stimulate in all 4 electrodes under 2, I think it's supposed to be milliamps, but 2, a setting of 2.0. An optimal lead placement is in the superior and medial aspect of the S3 sacrum, foramen. So we'll talk about how you can localize that easily. But the objective is that the lead should follow the nerve. And so over time, we have now got this curved stylet that allows the lead to have a little curve, and that follows the path of the nerve a lot better than the straight things that would go, the nerve would get further and further away the deeper aspect of the lead. So all of this has been very helpful in optimizing our lead placement. So, so we have kind of 3 A, B, C kind of cases, but a 40-year-old female with overactive bladder who had an initially good response with sacral neuromodulation, and she's having a declining response. What do you think? Have you guys run into that, where over time they sort of have almost like a tachyphylaxis, but is it really tachyphylaxis, or do you think there are other things that could be going on?
Well, I think it could be a variety of things, right? Did her battery run out? You need to reprogram the device. And to me, I don't think it's tachyphylaxis. I think sometimes your OAB gets worse, right?
Yep.
It's not a static thing. So the OAB gets worse. You just have, again, just reprogramming can often improve things. And just because the patient isn't doing great doesn't mean the SNS is a complete loss.
Right.
You can always add medication or add something else onto what you have.
So what are the steps that you take? If a patient comes in and gives you this story, what do? I mean, you want to make sure that the symptoms that they're experiencing are actually overactive bladder symptoms, right? I mean, did they start to get stress incontinence along the way? And, patients don't know the difference between stress incontinence and urgency incontinence unless you kind of help them understand that, right? So that's one thing. Are they feeling the device? Right? Are they feeling the stimulation in the proper place, which is, vaginal rectal or penoscrotal rectal for men? What's the intensity? Is it painful? Confirm that they're actually feeling it, because that could be, the battery going out, or the lead migrating, or fibrosis around the lead or something like that that's changed over the course of time. Check if it's on. Oh my gosh, we used to have patients come in all the time when we would check it and the thing wasn't even on. So I think, we live in sort of an electromagnetic world, and if you go to, Nordstrom or something, maybe walking out of the store, it turns it off. I don't know, but we've had patients. So we start asking them to check it before they come into the office first, because that's a big waste of $15 parking if they come in and it's just off. But and then battery life and impedances, right? So does anybody want to talk about impedances and what the significance of that is?
Oh, I was just going to say something before impedances. And some patients, you lead them through, some behavioral changes. Like I had a patient who, kid you not, drank 20 liters of fluid a day. She did not have diabetes insipidus. But, and I got her down to a normal fluid intake, and then placed sacral neuromodulation because she still had OAB. But then, is back in, this isn't working. And I made her redo a voiding diary, and she's back to, a decreased fluid intake of 12 liters per day. Yeah. So, I mean, clearly it's,
that's a lot.
You kind of have to sometimes step back to, like, what are you doing? Are you back to 8 pots of coffee a day?
Actually, that reminds me of a story. I kid you not. I had a patient. She was 80-something years old. In fact, she said, I have my boyfriend's waiting out in the waiting room. Don't tell him my age. But that wasn't even the funny part. If you talk to your patients, you get a lot more information. I said to her, how do you drink caffeine? She says, oh, no, honey, I don't drink any caffeine. I said, well, how much do you drink in a day? And she goes, oh, about a 6-pack a day. I said, a a 6-pack of what? And she said, Mountain Dew. I said, okay, switch to Sprite. And she did great. So, I mean, sometimes there's this hidden information that's really just right under the surface. And if we take time to talk to our patients, like this information comes out. She had no idea that that had caffeine in it. So, So, any other comments? Okay.
No, just about the impedances, as you asked. Impedances, as we typically explain to a patient, just essentially short circuits within the lead. And if there are abnormalities, many times you can program around that. But every so often, if it's multiple electrodes and you're limited in programming, you may have to revise a lead.
And I would say, to Sandra's point, sometimes we all have varying levels of ability to program these leads. And whether it's you or one of your PAs or other folks in the office, and if you're having issues, your rep will always come in and also help with programming. And I think it's imperative, and they will come in and certainly help out, and they can be a real help with that with difficult programming.
Yeah, I really would emphasize to lean on your reps because they can sit down and take the time. They have a vested interest in this thing working, right? As do we, but they really do. And so they'll sit down and go through all the programs, and there are advanced programs and things like that I don't even know how to do. But, I had patients that fell and, fractured their lead. They fell on the ice up in the Pacific Northwest, and you fracture the lead. That's going to, increase the impedances, right? So the electrons don't flow. So this is a fair question nowadays, is that if you have, if elevated impedances greater than 4,000 ohms on, electrode 1 and 2, but the others are okay, can you use those other electrodes? The answer is yes. So that's what Sandy was talking about when he said, program around the lead, program around the impedances. So you don't have to throw the whole lead out. But if you can't get good results, then you have to revise the lead, right? So these are things to consider. This is an old programmer. We just found a picture of that. But so the newfangled stuff with the smartphone looking thing, so it's kind of discreet. There are a lot of things in advanced programming that you can do if the patient's having pain, etc., discomfort. You can change the pulse width. You can change the frequency. All these little parameters. They don't have to be the standard settings, and these things can make a difference before you think about revising a lead. So that's a little bit beyond what we're talking about today, but just have this stuff in mind and don't throw the baby out with the bathwater, right? So we've kind of touched upon these things. Can you add other therapies, add medications, maybe add onabotulinum toxin? All of these things are options, but you really want to troubleshoot. You want to go through sort of a logical approach to trying to figure out what the problem is if somebody comes in with a neuromodulator that used to work and all of a sudden isn't working as well anymore. And for this reason, actually, we do follow our patients on an annual basis because sometimes the battery kind of fades off and they sort of get used to that as the new normal for them. And if you don't check in with them, they just go about their life with this overactive bladder that's returned, right? But if you check in with them once a year and you say, hey, your battery's dead, we need to change the battery.
Hey, KK, can you talk about how strong you want the stimulation to be?
Yeah.
In terms of, do you want the patients to feel it, not feel it, just below that?
Yeah, that's a great question because in years past, I mean, again, we've all been on this journey since 1997 when, I hate to say that, but, when this was first introduced and became FDA approved. And at that time, we would tell patients, turn it up as high as you can tolerate without it being painful. Oh my gosh. Well, now we tell them turn it up to, confirm that you're feeling the sensation in the right area. The bicycle seat area is sometimes what we'll call it, but, make sure they're feeling it in the right region to confirm that it's in the right place, and then drop it down one notch right under where you can feel it. Right. And so what does that do? That also increases the battery life because if you're maxing out the stimulation, it's uncomfortable. They come in and they tell you their toe twitches and all of this stuff. It's unnecessary because clinically, they do very well with it right under the threshold. Do you all agree with that? Any other comments?
And I know what I tell to describe it to patients is I tell them, you'll know if your device is on or not, but you're going to need to close your eyes and think about it. I said patients who have their device set properly have to go just a second.
Yep.
Yeah, my device is on.
Okay.
They have to really think about it really hard. It's not on their mind. It's like, I describe it like wearing shoes. You don't have to look down at your feet. You can feel your shoes, but you didn't think about your shoes until I mentioned it.
Yeah.
So that's where I tell people that's the sweet spot.
That's good. And again, this is sort of the language, right? I mean, how do you counsel your patients on, I have my special scripting that I use, but how do you guys talk to people about neuromodulation? I can start. I'll start because I caught you guys off guard. So I'll tell people, you can say I'm going to put a computer in your butt. They don't like that. So I say, this is a pacemaker for the bladder. It's the same as a pacemaker for the heart, same technology, same company started making it. Now there's a couple options, but basically what you end up getting, well, first of all, you get to take it for a test drive, right? So to make sure that it works, you take a 5 to 7 day test drive and make sure that it helps you enough to be worth getting this thing implanted, because you're going to have a little Oreo cookie sized battery. And so I had somebody say, single stuff or double stuff? And I said, no stuff. It's so, the thickness of it. You can say silver dollar. I think young people don't know what a silver dollar is, but the older folks or the people that go to the casino, silver dollar. But Oreo cookie, it's just friendly, right? I mean, everybody knows what an Oreo is, and it kind of makes you, it's kind of lighthearted. So
Oreo too.
you use Oreo, yep. Oreo cookie sized battery.
I'm in Cleveland, so we use double stuffed Oreo, though.
Double stuffed Oreo. So a little Oreo cookie sized battery in the lower part of your back. We do it under a local anesthetic. We do it in the operating room for the actual implant, not because it's a big operation, but we want it to be as sterile as possible. So you get colonoscopy kind of sedation, or the same kind of sedation you get if you get your wisdom teeth pulled. So that's friendly. It's not a general anesthetic in a big cold operating room, and you know what I mean? So that's kind of like, I think it's important. The same thing we'll talk about how you talk to them about on a botulinum toxin, but same thing, you want to use some friendly language. Anybody else use anything else?
No, I also sometimes describe it, it's like a little teeny micro TENS unit, because a lot of people are familiar with TENS units, that's programmed really specifically, that goes right next to the nerve instead of being really far away. And it's like electricity, it works better when you're closer to the source.
Yeah, no, that's great. Anybody out there in the audience have any ways that you
I'd
make
love
it
to hear
friendly?
them, though. Yeah.
Okay.
I think I tend to also, like you mentioned, emphasize the trial phase. I think this is really the only therapy we really have that allows you to try it before you buy it. And I think there's something very important about that, that's really a therapy that really lets you know, is this something I want to go on to or not? And so it's kind of stacking the deck in our favor. I think that really does help.
Yeah, I
That's
mean,
good.
I do that as well, and when I do it, I also emphasize, you don't want me to put anything permanent in if it's not helping you, and we're not going to put anything in if it doesn't really give a good response. If you come back and tell me, yeah, I think I'm a little better, it's not worth putting
Right.
in.
Right.
So I think it's also important to set up that expectation of what is going to be a successful trial.
What do you
Because when
quote
we-
patients for success? What do you quote?
So I'll tell them about 70% for urgent continence. I usually 50, 60% on unobstructed retention. And I think we all learned when we first started, we weren't necessarily as forceful of staying on that at least seeing that minimal improvement. You thought, oh, yeah, it's a little bit of improvement. The patient's hopeful. We'll put the implant in, then we'll do some better programming, and you'll get better.
Yeah.
And those were all disasters. So the patient needs to have a true response to put it in. Otherwise, not going.
And I try not to implant the 50% in their head. Like, I don't say things like, you need to be at least 50% better to get this implant. Because then many of them come back and will just repeat, I'm 50% better. So what I tell people is, what we want is this. I want you to come back and say, this is how it's going. This, no, and
Yeah.
No, or no. So
That'll
that's
be
what
a
I tell them. I
painful
said, tell me
patient.
how it's going, and they go like that. I'm like, okay. And then I say, how much better are you? But I'm not looking for So people are really resonate with that. So I'll see them in pre-op, and they're like, all right, great. And then I get into the details.
I mean, it's really a satisfying thing to have in our toolkit, because patients who do well, it's a life changer, right? I mean, it's really,
Big smile, and
yeah.
they're like, yeah. Like,
Right. I mean, the reality is, when it works,
Yeah.
because the patient tells you. It's very obvious when they have the.
I
good
mean,
response.
another way you can ask them, and this is more subjective, but is if we took it out and you went back to the way you were before this test stimulation, would you be happy? They're like, oh God, no, can you just leave it in a little longer? You get that. I mean, and so then you really know that this is worth putting
This
it.
even as a therapy, when you think about its invasiveness, especially if you do a PNE, it's really minimally invasive. And we have time even afterwards, talk about some kind of crazier, male patients with overactive bladder that, you know, didn't respond, but maybe they have some BPH, but they don't want to have some leakage afterwards. There's some kind of wonky scenarios that come up that it's like, well, you want to try it. I don't see any real harm to it. And then, you know, use that as a leverage to see if that works.
It's the other scenario. Sometimes you're getting reports back from your rep who's following the patient as well during that 2-week trial period, and it's unclear how well the patient is or isn't doing. And sometimes a good trick is just to have them actually turn the stimulator off for a day and see if they see an acute change and loss of the improvement that they're not sure they were having, and that will help you understand.
Now, there's
the
a little
truth.
caveat to that, though, because there is some memory, right? Some nerve memory. And so it is a little hard. It's not necessarily like on and off for everybody, right? Because the nerve still remembers that it was being modulated. Yes, please, if you don't mind coming I'm sorry it's all the way up here, but that way.
While she's walking too, I always make sure that we are treating their most bothersome symptom. If their bothersome symptom is nocturia times 4, and their urgency during the day gets 50% better, that person's not happy if their nocturia times 4
that's a
didn't get
good
better.
point.
So you really have to be like, what's important to you? So that's really like what I try to anchor on.
Yeah, that's great.
How long do you leave the PNE in? I had a patient who had, oh, sorry, can you hear me? I had a patient who had the PNE and had a UTI at the same time, and so she wasn't quite sure if it was helpful.
Yeah.
So how long are you comfortable leaving the PNE in? Like, would you delay removal before? Like,
Well, so PNE, the FDA approved max is 7 days. Yeah, so I would clear the UTI and redo it for her in that situation. If you, I mentioned before who we do staged in, right? So staged is if they're, pain tolerant, so they can't tolerate it, or if they have a pain component. The other thing is retention, because you need to have that in for a little bit longer, so that you can go 2 weeks for the staged implant. But in your situation, if she had a UTI at the same time, I would clear the UTI and redo it, because you're absolutely right. You just can't tell. And I would wait for a little bit after you clear the UTI, because you've got a little inflammation lingering there. So it's not really a fair trial. Yeah, great question. Thank you. Any other comments on that? Okay. I just wanted to show you a couple of examples here. Here's a gal. How do you think that placement looks? Oh, please. Yeah, please. No problem. We can move that into the middle. I feel bad that it's all the way up at the front, but
I'm just curious if you guys use Medtronic or Axonics, or if you have a preference for one or the other, if it really matters.
I would say that the answer is it doesn't matter. The technology is the same. I guess we can, I don't.
But I think it's easier to use one technology in your office because, there's the programmers and there's just the logistics. So I think, it's pretty tough to have patients with both, and then they don't remember what they had. And so it's your office should probably decide which you prefer to use. But that's just my personal perspective.
I use both. I use mostly Medtronic. I think if I have a smaller framed patient, I don't really prefer their rechargeable system. I'll just say it. So I use the Axonics because I think it's a little bit more forgiving for a recharging standpoint.
I think that would be the one possible differentiator. I use Medtronic.
Okay, so I have
Full
a
disclosure.
question. In the day of the 15-year lifetime battery, who's going with rechargeable systems these days?
Not me.
Yeah, I think it's a very, very, very small
Yeah.
number. And this is something I think we saw as well, years ago, that if you have a longer lasting battery, no one's going with the rechargeable. But again, you get a younger patient, someone with a really small frame, they may be more interested in the smaller.
And I will
device.
also add, with the longer life battery, if you're putting in an electrode and you've been working on it for way longer than normal, and you still can't get below 2, and you're at 3 or 3.5, at one point it's like, you know what? If the battery lasts now 12 years instead of 15 years, I'm okay with it.
Yeah,
So
I agree.
don't go crazy, because these batteries now have such a good lifespan that
12 to
it's not
15
worth the
years.
may not be worth the extra effort.
Agree. Okay. So, yes, please go ahead. Great.
I'm a nurse practitioner, and the doctor I work with, so she's just started doing PNEs about 2 years ago, and a lot of the patients recently have had better success with the PNE versus when they actually get the implant. So what are your thoughts, and what are you seeing on that?
Yeah, that is interesting. I mean, and we do see that, and I don't know that anybody has a single answer for why that might be. The nice thing about the actual implant is you've got a lot of different program options, right? You've got the advanced programming option. So I would certainly cycle through all that again with the help of your rep, because the PNE is actually much less precise, you know? I mean, so it's interesting that that occurs. But I mean, I would definitely not give up until you've cycled through all of the programs. Anybody else have any thoughts?
Yeah, I think it is a real phenomenon. I agree with KK. I don't think there's any good answer to that. It just happens. You do enough of these, it's going to happen. It's sort of a bummer. But I think to her point, you've got 4 electrodes, you've got multiple programming options as opposed to essentially a single electrode with the PNE. And then remember, there's probably some unspoken placebo effect, which is the one thing we worry about, and it's hard to really put. Most of my patients aren't bright enough to do a placebo phenomenon, or at least fill out a diary proving 50%. So that's where the whole placebo effect part is really harder to put a finger on.
Yeah. So I just want to show you a couple of examples of placement. How many of you guys think that this placement looks pretty good? I did. Okay, so basically, what are the landmarks? You want it to be as medial as possible. So here's the let's see. Let's see if I can get this to work. So here's the medial. Oh, you know what? It's probably sitting right on here. Here's the medial aspect here. I don't know why that's not showing very well. Let me see if I can do it with a pointer. Nope. All right. Oh, here. Okay. Here's the medial aspect. Oh, now I've got to, it's like robotics, right? I've got to like push so here's the medial aspect here and here. Okay, so it's pretty medial. Here is basically the SI joint comes in here, and the next bump down is the S3, right? So you want it to be, I always say about a centimeter above the maximal part of that hillock. We call it a hillock. Okay, and then you want the lead to be perpendicular in an ideal world to the anterior aspect of the sacrum. This is not quite perpendicular, and or parallel to the bone seams, which you can see on her, sort of here. So we could change the angle a little bit. If this were working really well for a patient, I'm happy with it. The clinical response, and in the OR, the bellows and the toe plantar flexion trumps, if you can use that word these days, but is like trumps the radiographic image, right? So this isn't too bad if it works. And it did work for her for a while. She was exactly that patient who came in and says it's not working that well. And ultimately, we decided to revise. So you can get a little bit better than that. This isn't bad. I mean, I'm happy with it. But, you know, when she didn't get the clinical response, we put it a little bit more median, a little bit more downward. So let me just show you. And again, it's a lot of clinical response. So we went a little bit more medial on this. You can see here's the original one. This is a little bit more medial. And then the angle of this is just a little bit, and again, this isn't actually perpendicular to the anterior aspect of the sacrum. That's what you aim for. But again, you really want to go with the clinical picture. So just a little millimeters make a difference because you're talking about a nerve, right? So it's worth trying to get, again, very much dependent upon what you get in the operating room when you put the lead in. Okay, so here's like 3B, 53-year-old female, a 53-year-old female with urgency incontinence. She did great with the PNE and not so great with the permanent lead, right? We just talked about that. I mean, that's exactly, thank you for that question. It's exactly that. I mean, we do see that for reasons that Dr. Vasavada just mentioned. Any other comments on that situation? Okay. Case 3C, patient had a sacral neuromodulation placed in 2012. Okay, now that's important because 2012 was about the time where we started to get more precise techniques that were dependable, radiographic landmarks and things that we could depend on. So this is right at that time. Modest efficacy with antimuscarinics was never really perfect. She's not feeling the sensation in the right place, and her IPG life is 0, meaning the battery's dead. So you're going to go in there and replace the whole thing, right? I mean, obviously. And you're going to use the precise technique that we have now, looking for landmarks that we can talk about. But actually, I'll have a picture and we can show you. Okay, how about this situation? Has anybody ever had this happen when you had an InterStim placed at someplace that, or sacral neuromodulation, I should say, placed somewhere outside, and they come and they say this thing never worked. So that's a shame, right? If they're walking around out there and they're in their head, or even some of us as surgeons, if you tried sacral neuromodulation before we had this guidance on the precise technique, and you think sacral neuromodulation doesn't work, right? Because you tried it back in 2010 or 2012 before all of this sort of, trickled down to all of us so that we could apply these techniques. We want to revisit and always be willing to look at things again. And for patients, I think that you don't want them to get discouraged and think that this technology doesn't work. So what would the next steps be for you all on something like this?
So, I think it's so disheartening when you hear that, because we've all heard it, oh, it never worked. Well, then in case, why'd you have it implanted, right? We have that trial phase to dictate if it's going to work, but they, regardless, had it implanted, and so now they come back. I guess one of the things you always have to make sure of is this really truly overactive bladder, and they're not missing stress incontinence. We talked about any other exogenous factors going on. You're back to your same things. Programming, check your device impedances. Do you need to do any programming changes? And then, at that point, same as you mentioned, kind of a lead revision.
How about this?
Were you
How about if you got
getting
this?
X-ray standard?
Yeah, how about that X-ray? Okay, here's the lead. First of all, it's an old lead. You can see it had a long one. Is this in the right place? No,
Battery's an interesting spot.
Right.
it's an
Her
interesting spot.
sacrum must hurt because the battery looks like it's right over her sacrum. So.
So it's wrong. I mean, again, what I always say is don't judge what we see today, something that was done 10 years ago by what we know now, because we just know more. We're more and more precise. Working well but annoying lower extremity, you can actually revise the lead because of that too. So here's one that we actually revised, and then we took the other one out. So this is much better. And again, some of this has to do with us just being better at it nowadays, right? Now I'm going to show you one, and again, I emphasize don't judge earlier placement by what we know now. So I'm going to show you, and this is like, in true transparency, one of my own patients who I did in '99, and then subsequently, okay? See, eat my pride. We didn't have X-ray at that time. This is a long middle lead. We used to do these have really long ones. So she was for retention. She actually responded, believe it or not. And then she became a urology nurse. But anyway, over time, we couldn't actually, this is the other thing. Look how deep those were. We just didn't know. I mean, that was when we were putting them in with the open incision. We didn't know depth, all of that stuff. We came to know all this stuff. This is like the history of neuromodulation right here. It's like the evolution of our thinking. And the upper ones are my more recent ones, obviously. But we tried to remove those down below. And they when they're that deep, if you're really going to go after, you have to go anteriorly for something like that. If you leave a ghost lead in place, can they get an MRI? Yeah. So what's a ghost lead? A ghost lead is when you pull the leads from that were placed a long time ago, and out come all the wires, and the little casing stays there. They can technically get an MRI, but now everything's MRI compatible, which is a very, very important question to ask people, like when they had their device put in and what model they had. Any other comments on that? Okay, so the take-homes for sacral neuromodulation are, engage your staff, consider batching, meaning like have all the P&Es in the same afternoon, for instance. P&E and PTNS, they tie up the room and the staff to different degrees. Lean on your reps, and we all get better with time, so we can't be judgmental about each other. And then lastly, I'm going to do case 4. 46-year-old woman with multiple sclerosis and overactive bladder. She's failed conservative measures, and she has actual detrusor overactivity on neurodynamics. So I'm going to actually pass the baton on to David. And then while he's coming up here, I'll ask you all what your minimal evaluation is. Is urodynamics actually necessary for these patients?
Yeah, I think one of the big questions I would always have in an MS patient also is how well are they emptying? And so I'd love to see a PVR of some sort. She's already tried and failed some of the simpler therapies. And then, how bad is her leakage, so that you can determine if you're going to go on to one of these advanced modalities. And then her dexterity, because as we'll talk about, is self-catheterization something that's going to be in her future.
So if you think about the neurogenic guidelines, if her PVR is low, you're going to essentially treat this patient like you would an overactive bladder patient. If PVR is elevated, then that may be someone who's going to benefit from a urodynamics, allow you to get a little more information. So I'm gonna keep going here to Botox, botulinum toxin, and we're gonna talk about this. So first of all, I'm gonna apologize now. I may leave a tad bit early because I have a session to moderate. I'm going to also do a big thanks to KK, which I've never done in all the years we've done this, because she is the leader of our course and always puts together our handouts and our slide deck together, even though I hate your slide transitions. Everything else about it is I love. So thank you, KK, for doing this, always. So that's some seriously small font. I don't have my readers. I can't read this. So this is, and I think I think it's actually the question is there, right? All right. So a 48 with bigger font. Hey, we can see that. A 48 one with frequency, urgency, and 3 to 4 episodes a day of urgent urinary incontinence undergo 100 units of oral botulinum toxin A. She will have the best results. So it's a multiple true false. Injections are focused along the trigone, delivered at least 10 injections. In the operating room, use it a rigid scope. Urine sterilized prior to injection. Gent is administered post-injection. Maximum dose 200 units. So, it says the poll's locked. We didn't even start. Or do I have to hit the button maybe to get it going? Let's see. No. Well, we'll come back to those answers later. We're going to talk about it. So botulinum toxin. So FDA approval for overactive bladder is 100. For an urgent intrusive activity is 200. But we can go both ways. Sometimes I'll use 200, not FDA approved dose for an overactive bladder patient. And I will certainly at times use 100 units for some neurogenic patients. So all the issues that we're doing in terms of preparation, diluting, preparing, in terms of, KK was talking about empowering our staff. I don't do any of this stuff. That is all done by our nurses staff in the office. I go in, I do the injection. It takes literally 2 or 3 minutes. And that is all the time that as providers we should be doing when we're doing botulinum toxin in the office. In terms of how...
David, real quick, can I ask you guys a question?
Yes.
There was some literature out of the GYN literature that suggested using Pyridium in advance in lieu of lidocaine. Have you guys ever tried that, or Urospaz, Urabel, one of the other analgesics? In lieu of lidocaine.
I don't.
I tried it once. It was really not a good day.
Our Urogyne, the GYN side of Urogyne at Houston Methodist does Pyridium, and they swear by it. I still use lidocaine, but yeah.
Well, interestingly, I've stayed on my lidocaine, but I think there's times where I'm squeezing someone in between the OR, between cases. So literally the lidocaine was placed and I'm literally going right in to do the injection. I'm not sure the lidocaine has done much, and they do absolutely fine. I think it's very patient specific, and there are certain patients that probably don't need anything when you do the injection.
If you do a number of botulinum toxin injections in a given clinic or procedure day or morning, it changes your efficiency dramatically, right? Because then it's essentially doing
Just go right in. Right.
So that there is some at least rationale.
Are they doing it for a couple days beforehand, or just right then that day?
I think it's that day. So
Yeah.
if they're coming in for a morning appointment, they'll take a Pyridium in the morning. But I don't know. Anyone else here have any experience with that? Try that.
All right, so everyone's going to come back to the course next year. Let us know how the Pyridium works with the Botox injections. So in terms of scopes, flex or rigid, depending upon the gender and what you have in your office. In my office, at USC, we just have flex scopes. So everyone's getting flex scopes, both men and women. And the needle is going to depend on the scope used. And I'm going to talk about needles because I think it's really important. So this is, I love this video. This is a video of one of my patients who had Parkinson's. and I was late that day. She was overdue for her Parkinson medications, so I'm not actually doing the injection on a boat in the middle of a hurricane. She just was in need of, she was shaking because she was in need of her injections. So, I'm usually, if you look at the PI, it was 20 injection site, 0.5. I'll do one injection. I would talk about that, how much you do in the injection. We're going to talk about how many sites, where you want to do it, and the trigone, which is a very interesting part of the injection. And we're going to talk about all of this.
Can I make a comment?
You can make plenty of comments.
That's a beautiful picture. I always tell our residents and fellows, you want it to look like there's a little bit of a groundswell. And so this is a beautiful picture of it. If it's too superficial, it looks like a hydrocele, right? You see this translucent, it's too superficial. If it's too deep, quote unquote, and you know how much is too deep, but you don't see any groundswell, right? You just inject it and you don't see the injection going in. So this is a picture of a really beautiful. I mean, sometimes when you're scything like this is a little bit harder. That's a little bit more superficial. But when you're coming straight on and you see this sort of groundswell, that's like what I think is.
So I would say I want to get a subtle rise, but I'm also not entirely sure that it matters. And if I get a bleb, I think it still probably works okay. But that's not my goal. So if you think about scopes, a rigid scope, it's certainly easier to do that for the women. The needles for the rigid scopes are much cheaper. I think especially if you're newer with injections, it's much easier to stay on whatever template is you want to be on. It's also harder to get out laterally, but also it's a one-person job because you don't need someone else to do that as opposed to when you use a flexible scope. One of the things, how you're driving the scope and the needle, you need someone else to do the injection. Certainly for men, it's preferable. The needles are much more expensive. And if you do it correctly, you also run the risk of impacting your optics, your fiber optics with the needle. So you have to be careful when you're doing that. So what scopes do you guys use? Do you still use rigid scope? I mean, you're obviously using flex scope on men. What are you using for women?
I use rigid for women, and it's an injection scope. So if you do enough, it's worth investing in an injection scope that has a working element that's almost like when you do a TERP, right? And you just go doon, 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 and it takes like 30 seconds to do Botox injection or on a botulinum toxin.
So rigid?
Same.
Rigid?
We've moved entirely to flexible, and I use half regular flexibles, but because I do a dedicated Botox day where I do 20 in a day, so we run out of scopes in the facility, so then I switch to disposable when we run out of reusables.
So at one of my institutions, we have disposable flex scopes, and they're fine. Although I will say, and I've just learned this recently, there are a couple times when I'm doing the injection, or I'm doing it with a resident, and I'm like, what is the resident doing? Like, they can't turn the scope and they can't get over. And I said, let me try this, and I can't do it either. And my understanding is with these disposable scopes, they'll go back and they may be the second or time we're using the disposable scope, and it doesn't deflect as well. So that's what I've been told.
Are you
So-
supposed to do that?
No, we send it back to them and they do it, and they send it back to us. Because it goes into like the disposable scope container, and we're not redoing it.
I was like,
I'm just putting in a little bit of alcohol. I'm putting it back in. No, we're not doing that. No. They send it back to you. They do whatever they do.
oh, I didn't know that they sent the same scope.
That's what I'm told. Because there are
They're
certain
going in
times.
the landfill.
Right.
Yeah,
I didn't
they're
know
being
that,
they're
actually.
being like
Well, there's definitely there are times when the flexible scope is just wonky with the deflection. Okay, so needles. There's a lot of needles to use. So what flexible soap needle do you guys use at the office? KK, stand up, Ann?
You know, I'm not even sure. It's the one that has the sheath to protect.
Olympus.
the fiber optic.
Olympus. It's sharp.
We do the same, Olympus.
Okay.
It's really sharp.
So these are the three primary needles available. So I used the Olympus needle. This was originally a GI endoscope needle. In my mind, is one that allows for the most deflection and it has the sharpest bevel on the needle. You do have to, as you can see here, where's my, oh no, I want to go back the other way there. Here we go. Hey. Okay. Just give me the darn pointer. Is it? Oh, here we go. I'm sorry, I didn't see that. So when the needle is not out, and then you push it in, the needle comes out there. So when you place this with the scope, you want to do it this way, so you are protecting your needle. Sorry, I didn't see it there. Yeah, it's not on there. So on the Cook needle, you have to preload this with the protection in, and then just pull it just back into the sheath. And then on the Labary needle, the advantage of Labary needle is you can change the depth as you want, how much the needle comes out when you do it. It's also to me it's my second, my number 2 needle when there's sometimes supply chain issues with the Olympus needle. I don't think it deflects as well as the Olympus is my only concern with it. And then in terms of a rigid scope, Williams needles are dirt cheap. So that's one of the advantages is if you are in your office and you are paying for your needles. I'm at an academic institution. They have no clue there are cheaper needles. This is the needle that I asked for. This is the needle they buy. Please don't tell anyone they're buying the most expensive needle. But then we're going to do this with the rigid scope, then which I'll do sometimes if I have to do an injection in the OR for whatever reason, then we use the Williams needle. Do you guys use any other needles? Anything else?
But definitely don't put this down your flexible scope. So if
That
you
would
run
be
out of
very
Olympus
bad.
needles and someone goes, you can totally use this, I'm like, I don't think I can. And,
No, you will trash
two,
your-
two flex scopes trashed that day.
So the other thing that I also learned when we first started with the Olympus needle, once I finish the injection, I just pull it out, even with the needle out. I think it's fine. And that also can impact so you need to put it back in the sheath when it's going in and when it's coming out, or you could have damage.
It's a very expensive repair too.
$9,000.
Yeah, it's really expensive.
Okay. So templates. There are a lot of ways to do the injection. And if you looked at how the FDA approved the trials left for FDA approval, it was 20 injections, 0.5 cc's per injection on a standard template, as you see there in the illustration. So I've kind of gone to more of a 1 cc in 10 spots. What do you guys do? And then we're going to talk about the Trigone in a little bit. There are a variety of there are people that have talked about 1 injection, 3 injection, all around, and saying that the outcomes are the same. And there are no trials looking at different templates, looking at this. And kind of the more recent view is we used to say, don't inject the Trigone. That was the mantra when Botox first started. Don't inject the Trigone because you're going to cause reflux. And then people did some investigation and realized you're not causing reflux if you inject the Trigone. And then it comes back to, well, maybe you want to inject the Trigone because there's a lot of afferent nerves there. What do you do with the Trigone? Are you trying to get some?
Yes, 2.
2?
Yeah, same too.
So
Never.
never. You're a never Trigone.
It bleeds and it really hurts. Like that injection really hurts.
So that's a really good point. If anywhere is going to cause you bleeding that's a problem, it's in the Trigone. And if it does cause bleeding in the Trigone, usually the bleeding goes away. I've had, since doing this since, I don't know, 20 years now, if not more, I've had one patient that had significant issue. I had to actually go back for clots. And usually, and you just like if you put your needle on the bleeder, it stops in 30 seconds. But it can bleed, and if it's bleeding and it's bleeding so much it's obscuring your view, it's sometimes hard. With the flexible scope, it can be very hard to get to it's harder to get to the Trigone in certain patients, for sure.
But as we'll talk about in a minute, probably about anticoagulation use. This is maybe the one patient maybe I did it with anticoagulation on, or those who stopped and had prior history, they're going to restart their anticoagulation as well.
So
Again,
I don't stop.
avoid the
I don't stop any anticoagulation.
No, I don't stop.
No.
Anticoagulation.
No.
Okay. So, all right. So this template. The thought is, this is where the afferent nerves are, and you think about how botulinum toxin works. It's blocking neurotransmitter release, and the take home has always been, well, it blocks the neurotransmitter release, the neuromuscular junction. There's no acetylcholine there, so you're not causing that bladder contraction. But it's naive to think that the only neurotransmitter that's being blocked is acetylcholine. That's not the case. And then there's the question, well, maybe there's some afferent neurotransmitter release that's impacting overactive bladder. That's also we want to impact. And again, if we're looking at where that's going to be, it's mostly going to be in that Trigone area. So I think it is helpful to get the Trigone. And then if you're impacting afferent more and less efferent, less risk for urinary retention. And that's what this one trial did show. Antibiotics. So there's a lot of data out there about antibiotics. So if you look at the original trial, you had 3 days of antibiotics pre-injection, 3 days of antibiotics post-injection. You think about many of the surgeries that we do in urology that are much more invasive than this, and we don't use 6 days of antibiotics for those surgeries, and certainly patients don't need 6 days of antibiotics for 1 day of an injection of botulinum toxin. So I usually do 1 dose the day of either Bactrim or Macrobid. What do you guys do?
I don't do antibiotics.
No antibiotics.
And, you know, we actually did a randomized study on a SUFU grant and powered to show a difference, and there is really no difference, antibiotics or not, if the urine's sterile.
So you say urine sterile. Do you check urine before you do your botulinum toxin injection?
Yeah, it doesn't have to be the day of, it has to be within, a week, whatever you want
to. Okay. We're going to talk about that.
Yeah, we do a single dose.
Single dose?
Yeah, I do a single dose of Bactrim, but I don't pre-check. I check their urine on that day, so I don't have them provide a culture a week ahead of time or anything like that.
We're going to talk about urines. We're going to come back to that. So what else in the literature? So there's data that shows adverse events aren't impacted by what's going on in the urine. So unless someone has an active urinary tract infection with symptoms, I'm going to go ahead and inject them. So I don't look at the urine because it's not changing anything unless they are truly having symptomatic symptoms. I'm curious, anyone else going with no antibiotics? KK, you're on an island here, but
And there's a comment in the chat. No antibiotics for anyone? Type 2 diabetes? Recurrent UTI history?
I mean, this is just based on that study that we did because we were thinking we were over-treating. We don't do it for cystos, and so, we just, and I think that it's okay, but therein lies the reason why we check the urine.
And I mean, also, full transparency, I did a study on neurogenic patients where we were doing a microbiome study, just like aside, and I queried every patient myself, do you have a UTI today? And they all looked me straight in the eye and said no. And we sent their urine for culture and microbiome. It's just part of the study, like not because I'm doing their Botox. 98% were positive cultures because these were cathing patients, and we had 1 UTI.
Right.
Out of 100, so it's.
I mean, I think we're not talking about UTI guidelines here, but the dogma's changed, right? We don't treat a positive culture; we treat symptomatic UTI.
And they all got a single dose.
Right,
of oral,
and I really first got into botulinum toxin injections initially with spinal cord injury patients, and to that point, those cultures are always going to be positive if they're catheterizing, and if the goal is to have their urine sterile, you're going to have to give them a course of antibiotics before every single injection, which is just completely unnecessary. So other studies have looked at a 1-day course versus or a 3-day course or more, and you get more infections with a longer course of antibiotics. 3 days of quinolone superior to ceftriaxone. I mean, I'm not sure we're doing either one of those. But there's some really interesting literature also that would suggest that in patients with recurrent UTIs with neurogenic bladder, when they were treated with botulinum toxin, actually their UTI rate went down. Theoretically, now they have a healthier bladder, less detrusor activity, better compliance, better able to take care of the potential infections that were going to occur.
And it's probably worth looking at your local antibiogram because I'm sure the Midwest has different resistance patterns than in California or Texas. So in the your hospital will have an antibiogram. So for UTI bacteria in the state of Michigan, Bactrim is a good prophylactic. So.
All right, so here's another question. We see if the poll will work on this one. A 48-year-old woman has urinary frequency urgency 3 to 4 episodes a day of urgent urinary incontinence despite maximal pharmacologic therapy. PVR is 15, 1 to 2 episodes a week of fecal incontinence. The next step is, and KK alluded to this earlier, and there is 100% correct, outstanding. Definitely someone with fecal incontinence, we're going to go with sacral neuromodulation. We're just trying to trick you with placing a sacral neuromodulation answer question in the part of the botulinum toxin slide set. That was my idea. And then looking at cath rates, this is the cath rates for patients with getting 200 units for neurogenic detritus or overactivity. But I think that's important. The point of this is to understand that just because you have a neurologic indication doesn't mean you should get 200 units. And I think Ann also alluded to this earlier, especially in those MS patients that are voiding on their own and don't want to start catheterizing, I'm going with 100 units in that patient. And then what do you quote your OAB patients on for their rate of the need to catheterize post botulinum toxin injection? 100 units. 100 units idiopathic.
100 unit idiopathic, I say less than 5%.
Yeah.
Exactly what I say.
Yeah.
In men, I say 10 though.
Okay. I say less than 5%, and probably, if you look at some of the data, it's probably closer to 2%. So if you think about how you decide 100 versus 200, certainly volitional voiders, low PVR, want to avoid CIC, or if unable to CIC, 100 units. 200 units if you're already on CIC, you're able to CIC, and you want max efficacy. And then there's the issue of, should you never consider botulinum toxin in someone who can't catheterize? And that's kind of the mantra. But I will say, if I have no other option, and the only other option may be an indwelling catheter, then you can always try it. And if they go into retention, you put the catheter in. Yes?
Do you quote a different CIC rate in patients with diabetes?
Oh. Can I? So the question is, do I quote a different CIC rate in patients with diabetes? You ask a very good question, because look at the next slide. Did you look at my slide set? Thank you. Perfect segue. So CIC is post-injection. We talked about the kind of the timing. So how do you handle that, essentially that initial, if I'm doing a repeat injection, we know the patient's doing well, I don't see them back in 2 weeks. But if someone is a new injection, I say, I want to see you back in 2 weeks. But if you're doing great, I don't need to see you back to check a PVR because it's not going to change anything. Make it a telemedicine visit. Save the gas, save paying $15 for parking in Cleveland Clinic. We can do a telemedicine visit. Because I don't care what the PVR is. If they're doing weight, I'm not starting them on CIC. But yes, there is data that would suggest that if you're a diabetic, the retention rate is going to be higher. So, but I don't know that it's going to be this high, because I don't think it's 6.3% on patients without diabetes to begin with. So, but I do believe it's going to be a little bit higher, but also it also depends on, all patients with diabetes are also not the same. So
I think this is a good point, though. If the patient is doing well clinically, it doesn't really matter what the PVR is, right? If they're doing well. So, and the pendulum's going to swing. We know it. I mean, unfortunately, it only lasts 6 months on the average, whatever it is. But that means the sort of adverse effects also are temporary, right?
So there's one other thing about this duration of response that I've actually taken me a long time to wrap my head around. So if you think about the trials, duration of response was when did you qualify for reinjection? To qualify for reinjection, you had to come back to 50% of your baseline degree of incontinence. So if Mrs. Schwartz has 4 episodes of virgin incontinence a day, to be reinjected, she had to come back to 2. So if Mrs. Schwartz went from 4 episodes of incontinence a day to 1 episode of incontinence a week, she is not going to wait till she has 2 episodes of incontinence a day to want us to re-inject her, right? She wants to be re-injected when she has to have just any kind of repeat injection. So it's probably may not last as long as what the package insert says, because our trials were having to come back to a certain degree of incontinence, whereupon our patients want to go right back in to get re-injected the moment they start to have any leakage again.
David, question from the chat. If you give someone a PVR of 500, is that okay?
If someone's doing great, I am not starting them on catheterization. Now, 500 would be pretty high for someone to be doing great and have no symptoms, but every now and then that's okay. I will say there's some that, like, I'm a little bit better, and then they have their PVAR of 300 or 400, and I'll say, well, you can catheterize probably once a day and do okay. And some will say yes, some will say no. At the very least, if they're there and they're having a high PVR, I'll do one in and out catheterization at that time if they'll allow me to. But kind of sometimes it's a discussion or I'm trying to get them to.
And again, qualified that, no infections, they complain their stream is slow, but urgency is better.
If they're happy, I'm not starting catheterization. And that's part of the challenge of if you look at the package insert, I think it says we need to start catheterizing at a volume of 350, and there are patients that are doing fine with the PVR of 350 or higher.
Right, and remember those rates of catheterizations were based on pre-specified criteria
Volume.
that they had to start self-cath.
It was
Whereas in
200
real
to
life-
350. You should consider it, 350 or above. You had to.
Right, and in real life, we all would, as we just talked about.
But wouldn't you
know,
creep
slow
that
down.
person down to 50 units next time? Like that person who went into 500 cc retention, I'd probably go, maybe we should try 50 units next time because you're such a great responder.
Yeah, that's something to consider. So to move along, so we can get things that concern. I mean, if you look at all these different lists of people you're going to be concerned with, usually it's just men with some degree of evidence of bladder outlet obstruction, and those are the ones that certainly are going to be a greater risk for not having a good response or going into retention. So think about that. So if you think about what's the right patient and what's the wrong patient, to me, certainly someone with overactive bladder, urgency urinary incontinence, urodynamic detrusor overactivity, though again, urodynamics are absolutely not required to move along to any of these therapies, able and willing to do CIC and neurogenics. Someone suboptimal, if you can't or won't consider doing CIC. If there are bowel issues, again, we talked about neuromodulation, maybe your next better step. High PVR at baseline and bladder outlet obstruction. And then I think my last slide is just talking about, yes, there is a little bit of data, not a lot, looking at patients that have failed SNS, and Botox can be someone that can potentially rescue that. So take homes, certainly you can do it in the office, well tolerated. Use the scope that works for you. Certainly protect your fiber optics. The answer to that question was, on that one question was, I think, looking at the Trigone, do not use aminoglycosides in patient botulinum toxin because it increase the effectiveness of the botulinum toxin. Not better. Patient comes in, they're not better. Or if they say they're worse, it's either a UTI or a high PVR. So check a PVR, check a urine, and using caution in patients with bladder outlet obstruction. Thank you.
Thank you, Dr. Ginsberg. So we just wanted to tell you a little bit about what the future is. I'm going to ask Dr. Vasavada to come up and tell you the future is actually here now. It used to be the future, but now it's here. So we're talking about implantables.
Yeah, exactly. And this part has changed since literally a year ago. So it's kind of cool. The future has crept up on us. So looking at a situation like this, a 64-year-old woman has failed 2 medications for overactive bladder. She's not interested in the current 3 refractory overactive bladder options, and read on Google that there's some other new options. How would you guide her on potential new therapies? So this is real. These are patients. They're doing research. They have different ideas, and I think I heard a friend of mine say that the patients tend to choose what they dislike the least as far as these options, and I think there's probably a lot of reality to that, unfortunately. So, new technologies that have been out since perhaps last year at the same time. Valencia Technologies has launched their eCoin. It's an electroceutical coin. It's the only fully implantable tibial nerve stimulator because it's essentially, if you will, a lead and generator in one unit. It is essentially a primary battery, and it's shaped literally as you see it here next to a nickel. So it's a pretty small therapy device. It doesn't actually have a lead. So this is the stimulator and lead essentially built into one system. And then when they looked at some of their data, and I'll show you some of this, it's overall been pretty good. It's been implanted subcutaneously above the fascia. So this is a above the fascia approach to placement of a small device in that lower leg, nearby or adjacent to the tibial nerve. The quoted timing to do this is very quick, about 15 minutes, typically done as an office-based or outpatient type procedure. Blue Wind has launched their device called the Revi. It's an implantable unit in proximity to the tibial nerve. It's an external stimulator. So now this is actually more of like a receiver. So that gets implanted, and then they'll use an external stimulation device to essentially power that device. That the patients in the trials had done it every day for 30 minutes. And then when they do the follow-ups, many of them in the longer term follow-ups did it probably about 2 to 3 times a week. So they definitely decreased it with time. So as we sort of talked about with the PTNS, you're going to need to do some level of stimulation over time. So the electroceutical coin is delivering a small amount of intermittent stimulation, and this is very similar in that sense that you're doing a stimulation when you put this external charger around the ankle on a daily basis, which will then deliver the stimulation that the device will do over the course of a day, redo it the next day or the next day, et cetera, et cetera. So final points. You want to take it from here? Or you want me to go ahead? Okay. So just from a practical standpoint, tibial nerve stimulation, as we've seen now, I suspect more of our patients will migrate from the office-based once a week tibial nerve stimulation more to implantable, is my guess. KK, final take-home points on sacral neuromodulation.
Thank you. So we're in the home stretch here. Just really, thank you very much, Sandeep. So from a practical standpoint, things have changed just a little bit. I think really when it comes down to it, we've got all of these things in our armamentarium, and you have to tailor it toward your patient, right? So the only things that we were talking about is, like dual incontinence may be something that you would only do sacral neuromodulation for. But if you look at it as pros and cons, right? So sacral neuromodulation, the pros are that the battery life is 12 to 15 years now. You get to take it for a test drive. You really don't have the risk of retention, and you can treat global pelvic floor issues. The cons are that you've got an implanted device that can malfunction, you can, fracture the lead, it can migrate, all of it get infected, that sort of thing. It's a 2-stage procedure, so there's a little bit more of a hassle factor on the upfront investment of time and energy for the patient. Technically, it's not for neurogenic bladder, but now that there's MRI compatibility, it's really for frequency and urgency, refractory overactive bladder symptoms, or idiopathic non-obstructed urinary retention. So just don't call it neurogenic bladder when you code for it. For onabotulinum toxin, there's nothing implanted. That's a big pro. They can do it in the office. They can drive themselves. They don't have to, have a driver. Actually very, very well tolerated. The cons are this little risk of retention. But again, retention, what's retention? Incomplete bladder emptying, it's really not clinically significant if the patient is doing well, right? They don't have to CIC or anything like that. There is a risk of UTI. We're finding, with this study, again, somebody asked in the chat whether or not we meant no antibiotics for anybody. There are people, obviously the diabetes patients or neurogenic bladder people who have recurrent UTI, that sort of thing, we're going to treat them. The durability of response is less, so it's on the average of every 6 months or so. We usually will make an appointment for the patient, just like when you get your teeth cleaned at the dentist, you make your next appointment on the way out. Otherwise, it becomes an emergency the week of, like, oh, I got to get in right now, right? So the take-home messages really are that we've got a plethora of successful options. We just have to get comfortable with them, know the tricks. Practice helps. Like, don't be impatient with yourself. You get better with time at all of these things, especially something like lead placement. And we can go into a little bit more detail about lead placement if anybody's interested, or we can talk about it afterwards. But we must keep learning. As you've seen, there's been evolution. Just when you think you can't think of another thing to do, somebody comes up with some brilliant idea and new stuff. From year to year, we've seen it as we've done this course, how our armamentarium has evolved and advanced. So we have to keep up with the times. Even just the technique of placing the lead, for instance, has improved over time. So always be looking to, keep up to date and learn the new tricks, because something that was the case 10 years ago, even with the same technology, we've gotten better at it. So it's really important, I think, to keep up with that. So any other questions? Yes, please. Okay, so the first question, and I'm posing it to the panel as Dr. Ginsburg leaves to go moderate a session, but do you do pre-testing before you do an implantable, do you do a PTNS test?
Yeah, that's not required, so no. I think some of the insurance companies are suggesting that for them to cover it, but so far, no, that's not been required. So to your question, yes, it's essentially a primary implant on those patients.
Your second question was, so that's just like a sacral neuromodulation. We wouldn't necessarily unless it bothers them, right? I mean, really, there's no reason to do another procedure. It's not going to hurt them if it's placed in sterile fashion. Do you agree?
Yeah, no, I think it's one of the concerns that I think people are going to have. That said, when you look at some of the other trials, they weren't looking at a bunch of these patients who completed the trial and said, I want this thing out. So that said, the success rates were quite high. And I didn't show that here, but for sake of time, but the reality is, yeah, the success rates were high, so most of those patients continued to do well with the long term, so they didn't feel they needed a device removal. Now, as we go out in the market now, and these are marketed, yeah, I think you can imagine a patient who has mixed symptoms, and maybe they have some stress, I don't like this thing in me, and then battery changes for the electroceutical coin. The estimated battery life is at least current technology is 2 to 3 years, so then you're going to have to change that as well.
Yeah, and you had a third question. My apologies. Oh.
Not in Michigan.
We're just embarking on it, actually, so we haven't run into any problems yet, but, N of 2, so.
Yeah, I believe there's currently tracking codes because it's a Category 3 device, so at this point in time, the facility fee is going to be reimbursed, and there's some differential between if you do it in a hospital outpatient facility versus an inpatient type facility. But that said, it is covered from that standpoint. The physician's fee, to my knowledge, I think you have to put a close similar technology, and most of us will probably use the 64561 code, which is the sacral
get to
neuromodulation
the
implant
questions.
code.
But I do think it's covered at the VA currently. So at least at the VA in Michigan, which is probably the case nationally, that it is covered. So again, it all depends on, insurance providers and who is covering. And again, that's probably going to, because again, I mean, the cost to a patient for one of these things off insurance would be astronomical. So
Yeah. Any other questions? We're going to do the post-test, which is the same as the pre-test, but hopefully we got you guys thinking about something. So please scan the QR code one more time. And we'll try this again. Okay, guys, all set? All right, so question number 1 is, despite 6 weeks of mirabegron, a 69-year-old woman with recurrent urinary tract infections has urgency incontinence. She has early dementia and a cardiac pacemaker for bradycardia. Her exam is unremarkable, PVR at 125, and UA is negative. The next step is, so I'm going to put it to the poll, but let me let you think about it for a second because you only have 15 seconds on the poll. Can we see them now or? Oh, so it won't let us see the. So I'm going to go back for a second while thanks, Jake. Jake's going to try to see because it's interesting to see how we do. But the bottom line is that adding solifenacin, probably not. She's already got a little bit of an elevated PVR. She's got early dementia, and there's the worry about the anticholinergic effect on cognitive abilities. Percutaneous tibial nerve stimulation. That sounds like a good one, but what's the problem with it? She's got a pacemaker, right? And so it isn't either one of the percutaneous or the implantable are contraindicated. Onabotulinum toxin. Probably not great because she's already got a little bit of a PVR elevation. So sacral neuromodulation is a very reasonable thing to consider. And you can put sacral neuromodulation in with a cardiac pacemaker. Did I get the right answer?
yeah, and again, sometimes those patients will empty better as well. So that little elevated PVR
That's right.
is like, oh, that sounds like
That's
a better
right.
idea. And the recurrent UTIs and botulinum toxin.
That's right.
It's always a little.
Yeah, that's exactly right. Okay, any questions or comments on that? Okay, so we'll go to the next question. Which of the following might be considered the most effective method of counseling for third-line therapies? And the key is the Oreo cookie. No, it's just friendly language. Whatever it is that makes it a little easier. I think we've all gotten a little bit better about, using, what do you call that? Examples. Analogies. Yeah, thanks. Gosh, I had a word block. Analogies with telemedicine now, right? Because you can't like draw things for them as easily, and you're trying to hold it up to the camera and it's not lining up and they can't see it. You come up with different descriptors now, I think. Have you guys all found that a little bit? Like you come up with some language to try to describe things to patients. So anyway, I've always used Oreo cookie, but I mean, I think the friendly language is nice to have. And then the sedation is not a general anesthetic. It's not a big operation, that sort of thing. So I think those are good. For onabotulinum toxin, I say it's the same Botox you put in your face. Like anything you can inject in your face, you can inject down there. So
When I started at Michigan, they already had a canned handout, and it started with, onabotulinum toxin is the most potent neurotoxin in the world. And I'm like, all right, we need to change our handout.
Yes.
You're
And that's
like,
a true
wow.
statement. It is. Like, whoever thought to do that in the first place? Some I was going to say madman, but mad person. I mean, now it's ubiquitous. We use it for everything, right? And so people are very familiar with.
Call it Botox, not botulinum toxin.
I know, that's
I
true,
try
but
not to
I'm
use
trying not
brand
to use the
names,
trade
but
names.
yeah.
But, okay. So everybody's going to.
And the AUA is not going to show audience responses. It's just a new policy. So although we're asking people, you're going to know your own answer. We aren't revealing the
is that right?
audience answer.
I didn't
yeah,
know
he
that.
Just told me so.
Okay.
So
Okay.
there's nothing
Thank you.
malfunctioning. It's just the way it is.
Okay. All right. So the next one is a patient undergoing placement of a lead for sacral neuromodulation elicits bellows only. And my apologies, we didn't go in detail into the placement. And again, I'm happy to stick around and talk about little tips and tricks on that. But in the interest of time, we didn't do that. What would you do if you get bellows only? Would you move it down one level, up one level, pull the lead out, push it in, increase the level of stimulation?
Hit the floral pedal. Beep.
Yep. So here's this, and we'll talk through it. So bottom line is, we've got S2, 3, and 4, right? If you put it in S2, you're going to get a rotation. You're going to get a buttock or a leg twitch, like a rotational kind of a thing in S2, all right? Lead 3, Freeman 3 is exactly where we want it. You're going to get a bellows response, which is, what a bellows is? It's the thing that you fan your fireplace with, that thing that. So basically, it's your pelvic floor is kind of contracting up, so the buttocks move, okay? And you get great toe plantar flexion. So that's what you're aiming for. In an ideal world, you get bellows before you get the toe, but that's really getting a little nitpicky. But you can get to the point where you're really fine-tuning your technique with that. Bellows only is S4, which is fine. If you're doing it only for fecal incontinence, then S4 is actually it's not quite as specific as it is for urinary retention or urinary symptoms, but you're aiming for the bellows and the toe. So what you would do, it's not even loading now. If you get bellows only, you're going to move up one level. So you use all the information. And by the way, one of the other technical things is if you get bellows only, you leave the needle there, right? Because it's a placeholder, it's information. And even if you get bellows and toe, but you're at 2.1, you leave the needle there and you dance around that needle, right? You change your angle, you move it up a little bit, you try to get a little more medial, a little bit more superior, but you leave your needle in there because that's information, right? So that's sort of the fine-tuning tips. So question number 4, despite timed voiding and caffeine reduction, a 45-year-old woman has urinary urgency and frequency 10 to 15 times in a day. Her exam is unremarkable, PVR is only 15, and her UA is negative. She's not interested in long-term pharmacologic therapy and is unable to do physical therapy due to scheduling issues. She would like to proceed directly to sacral neuromodulation. The next step is no treatment since she doesn't want medical therapy, additional behavioral therapy, trial of tolterodine or mirabegron, or go ahead and proceed with sacral neuromodulation. What do y'all think? How many say E? Yeah. So E, now you can do that. Even the prior iteration of the guidelines stated that this is not an algorithm. You don't have to do first line before third line, but we generally would. But now, really, you can do what the patient would like. I think that's a nice advance. Okay, last question. You guys all hung in there, and we're going to finish right on the minute here. A 53-year-old woman's OAB symptoms are not improved 2 weeks after injection of 100 units of monobotulinum toxin A, and the next step is reevaluate 2 weeks later, check post-void residual, add mirabegron, re-inject with another 100 units, or consider sacral neuromodulation. What would you guys say? I mean, I think there are two things there that I would choose. So you might want to check.
Schedule her for a PVR in a week from now.
Yeah, I was going to say the two, A and B, between A and B, right? You want to check and make sure she's emptying completely, and you want to check it out. Because, you know, the other thing that we probably didn't mention is that Botox, when you inject it, I always tell patients it's not going to happen. It's not going to work today. It takes about 7 days or so, or, you know, give it a week. Don't get impatient or don't be discouraged if it doesn't work right away. And with that, I think we're at the end of our time. So
And the new guideline is posted on the AUA website, the abbreviated version as well as the full-length version if you're really feeling interested in OAB in depth. So both of those are posted. They're available for free on the website.
please, oh, yes. Do you have a question?
The statement about moving on to sacral nerve stimulation without trying pharmacotherapy
Mm-hmm.
from the guidelines is one thing, but the insurance is that they
Right
try
on.
to make 6 months of therapy first.
Yes, you're absolutely right. I mean, it's documentation. Sometimes you just have to play the game and say the patient tried meds and didn't tolerate or too expensive, whatever it is. I mean, you're right. It's unfortunate, but a lot of things outside of clinical medicine dictate how we practice.
But maybe guidelines will help move the needle on that kind of non-patient centric care. So again, that's what we hope, is that the guidelines will be used to help clinical guidance, but also help insurance and policy guidance.
Thank you all so much for your attention and your attendance and participation. If you could please give us some feedback, we would really, if you want more of something, less of something, more interaction, whatever, please, we really take that seriously. And have a wonderful meeting. Thank you very much.